Lumbar fusion is indicated in patients who have radiculopathy, which is pressure on a nerve root causing pain that travels down into the buttocks and legs. This can be accompanied by numbness and weakness, or instability. And instability is where the spine is moving more than it ought to. That movement usually causes back pain, it usually causes muscle spasm, and in many times it can cause pressure on the nerves and radiculopathy as well. Somebody who has these types of findings and symptoms would be a good candidate to consider a fusion in if a simple discectomy or decompression won't be enough to take care of it. A lumbar fusion is a procedure where instead of simply decompressing the area where the nerves are, stabilization is necessary. So for example, if the problem causing pressure on the nerve involves a space which requires removal of bone that will then secondarily make the patient unstable or move more than they ought to, then stabilization of that area would be needed and would be performed through something called a fusion. So lumbar fusion is performed in a number of different ways. I perform lumbar fusion in a minimally invasive manner. I do so with a small incision as I can do and still carry out the job that needs to be done. I drop down to the space where the nerve is being impinged upon or squeezed. First by defining where my bony structures are. I do that by placing pedicle screws. Pedicle screws will tell me where the space above and below the exiting nerve root is, and I can actually use the pieces attached to my pedicle screw to retract tissue and to expose the area that I'm working in. Once I've done that, then I take away the bone, ligament, and disc that are pushing on the nerve root as it's leaving that space, and I restore the natural disc height by placing a spacer in that disc space after I've uncovered the nerve root and got it out of the way. That spacer does two things. One, it acts as a scaffold for the body to build bone through, but also it returns some of the natural disc height that has been lost that oftentimes contributes to the narrowing of the space where the nerve goes out. And so by doing that, not only are we removing bone spur and ligament and the other tissue pressing on the nerve root, but we're giving it more room by restoring some of the natural disc height. Once you've done that, stabilization is needed, and that stabilization comes in the form of screw and rod construct. The pedicle screws are already in there to help with the identity of where structures are. They are placed under X-ray, and then once we've completed the decompression, completed the spacer that goes to restore natural disc height, and that's all been completed, then what we do is we lock that space down and stabilize it with a rod that goes from one screw to the other and caps which lock that in place. That screw rod construct can also help in the case of people who have instability, who oftentimes have a slippage of one bone on the other. That slippage is called spondylolisthesis, and oftentimes what it is it's the bone sliding forward on the other so that you have a mismatch of the openings where the nerves go out, and that creates narrowing. I can actually pull that mismatch back into good position using my rod and screw construct. Because we do this lumbar fusion in a minimally invasive manner, people are able to go home the next day. They're able to be up and walking just hours after surgery. Many times the pain that they were experiencing in their back and legs is significantly reduced, if not gone, immediately or very shortly. There's of course incisional back pain that goes along with any surgery that you have on your back, but that usually goes away fairly quickly as well. I do restrict people when they're lifting and they're bending and they're twisting. I try to do so with instructions, a 20-pound weight limitation, and telling them not to bend, lift, and twist, but I do also put them in a lumbar brace. This lumbar brace is rigid and it reminds them when they try to bend or move that they're not supposed to do that. It creates some barrier to them just bending over and picking something up, and so they have to remember to use their legs, or they have to learn to bend differently than what puts pressure on the spine. Generally, people can be back to work as soon as 2 weeks, but if they have requirements for heavy lifting, bending, and twisting, then usually they have to wait for about 3 months.